Welcome to a CME podcast episode from NEI, the Neuroscience Education Institute, hosted by Dr. Andrew Cutler. For complete CME information, please refer to this podcast's description page or go to nei.global/podcast.
Hello and welcome to another NEI podcast. I'm Dr. Andy Cutler, and I'm very excited today to be talking about a topic that is of really large clinical significance. Not well enough understood still, even though we've been talking about it for a few years. And of course, the accurate treatment is important, but we're going to really focus on the patient today. And with me is a good friend, Desiree Matthews. Desiree, how are you today?
I'm doing well. How are you doing today?
Doing great. And I had the pleasure of co-presenting with Desiree at the recent NEI Synapse conference. And so, Desiree, we're going to have an interesting conversation here today. But why don't we start out with maybe helping the audience to understand how do we recognize tardive dyskinesia in our patients?
So that's a great question. I like to let healthcare providers understand that although we may be very interested in hearing what the patient has to say, we're always using a lot of active listening. It's really important for us in mental health to also be looking at our patients and really keeping TD at the top of our mind, because it's something that can easily be forgotten about in our assessment, because again, we have a lot to do in our office visits, and the tardive dyskinesia we see in clinical practice can actually be very difficult to detect if we are not using an assessment tool like the AIMS or the DISCUS, or even a clinical assessment like the MIND-TD scale or the IMPACT-TD scale that we'll get into later today. But we really need to be keeping our eyes open for TD and also listening to our patients for clues that they may be having a drug-induced movement disorder like tardive dyskinesia.
Boy, that is such a great point you just made. Obviously, we need a high index of suspicion, but what are some of the things that patients might say that might make your ears perk up that, hey, maybe there is something going on here?
So from my clinical experience, I've heard patients describe tardive dyskinesia as teeth grinding. Maybe they were having problems wearing their dentures, shaky feeling or twitchy movements, actually telling us that they're having impairments texting on their cell phones or being able to hit the right keys on the keyboard. And some people actually say that they first noticed tardive dyskinesia as an eye twitch. So they say, Desiree, I've noticed my eyes starting to twitch and it seems like I'm blinking a lot. So if you listen closely, you can pick up on, just from a chat with a patient, that they may be having symptoms related to tardive dyskinesia.
Wow, that's really helpful. Yeah, I think it's true that sometimes we think of this as a movement disorder, and so we focus on the movements, but not always on how it can affect people and the impact, as you said, of TD. So it's also very important, as you said, to not only listen, but to look for it. And I think you're right that we have so much going on sometimes that we don't look carefully sometimes at our patients to see what's going on. And I guess a simple question might be, have you noticed any abnormal or unusual movements? Or has anyone else noticed?
That's exactly right. And there's screeners out there, as you mentioned, asking that first question about movement. That's actually part of the MIND-TD scale. And this is something that any clinician that's been trained to use this scale, it's freely available, can use to initiate that conversation with a patient. So this could be somebody checking the patient in, like a medical assistant. It could be even a therapist or a peer support person working with that individual. Screening for tardive dyskinesia is not just about the person prescribing that antipsychotic. It really takes a team to notice these movements of TD. In many cases, I've missed the tardive dyskinesia movements myself, but it was maybe the injection nurse that noticed the movements because they were spending a little bit more time with them.
Yeah, that's a really good point, because these movements can come and go. So they're not always readily apparent. I guess it's just important that any patient who's on an antipsychotic medicine, we have to have a high index of suspicion. And the newer guidelines even say that at every patient encounter, we need to be assessing for this, maybe not doing an AIMS at every single encounter, but as you said, ask about it and look for it, very simply.
And I think one of the big advantages that I find in my practice, I practice solely telepsychiatry. Oftentimes, I have readily available care partners, caregivers, family, friends that live with the patient. So I also include them in the assessment of tardive dyskinesia because, as you know, Dr. Cutler, we often hear our patients say, oh, I don't notice that movement until so-and-so, my brother or sister, loved one pointed out that movement to me. So in some cases, it's quite common for patients not to recognize it until someone has actually pointed out that movement.
Yeah, it's a very funny thing about the pathophysiology about TD that it does not have a sensory component. So patients may not notice or feel these movements unless maybe there's secondary complications, like as you mentioned, grinding the teeth or having a sore in your mouth from moving your jaw or your tongue around. Maybe, moving your feet or your toes in your shoes and getting a blister or something like that. But you're right that they may not feel the movements themselves initially. And very often they may not connect that it's due to a medication they're taking, and they may think something else is going on. As you mentioned, sometimes people have jaw or teeth grinding and they'll go to their dentist and ask about this. So I guess you're right. It's a team sport. We need to all have an index of suspicion.
That's exactly right. You brought up a great point about these individuals that are at risk for developing tardive dyskinesia. They're seeing other healthcare specialists, right? They're seeing their primary care doctor. They're seeing the dentist. If you don't mind, I'd love to share a patient story about how it really weaves right into this. So I had a patient had been on a second generation long-acting injectable antipsychotic for over a decade, right? And she had been going to her primary care doctor's office for treatment of upper back spasms.
Oh my.
So she was in chronic pain. She was prescribed muscle relaxers. She was prescribed even narcotic opiates to treat her pain. And she said that her pain medication or her pain management was just not doing it. She wasn't finding relief. She was having a lot of pain. And one day she came into the community mental health center I was working at, and the injection nurse pulled me out of my office, actually, and said, hey, look at this individual. Look at how she's walking. So when she was walking, you could actually see the dyskinetic movement. You could see the movements in her neck. Her shoulders were shrugging, and you could see the TD in her trunk. And I talked to her. We did a whole AIM screen. We talked about it. And she noticed the pain, but she didn't recognize the movements as tardive dyskinesia. In fact, she did not even realize that her mental health medications could cause this. So that was a really interesting story where, again, the patient is feeling the impact quite clearly, but she wasn't able to connect, A to B, right? She didn't even understand what tardive dyskinesia was and that it was a risk. So this is really where it takes a whole village to recognize and make sure these individuals get adequate treatment. But to fast forward, the good news is we did treat her with an FDA-approved VMAT2 inhibitor. She did have improvement in her mood and the pain did go away. So we were actually able to help work with primary care to taper her off of the opiates and get her off of the muscle relaxers. So that ended up to be a good story in terms of just being able to recognize that, again, it's important to ask and dig deeper. And it really takes a team to catch TD in some cases.
Well, that's a terrific case and story. And there's so many things that this brings up, including the fact that TD can present in non-traditional ways. I don't know about you, but when I trained many years ago, we were taught it was mostly the face. It's an orobuccal-lingual dyskinesia of the face, jaw, lips, tongue. But the fact is, it can affect any part of the body, and the case you presented is an excellent example of that. So we really do have to go beyond just the face, I suppose. You mentioned a couple of ways that we can assess the presence and the severity. And of course, the AIMS is a critical tool that we're trained on. There are others. You mentioned the discus, which is not as commonly used. But what I like about the AIMS is it does assess the entire body, and it gets you to systematically assess the entire body. You mentioned the MIND TD and the IMPACT TD scale. I think these are terrific tools. These were two developed by the two different drug companies that make the two FDA-approved VMAT2 inhibitors. So the MIND-TD scale, I believe the MIND stands for, and you correct me if I'm wrong, but M is movements, the I is impact, N is, I blanked out. I just had it a second ago.
Notice.
Notice. Does anybody notice, or do you notice? Yeah, and the D is differentiating, which is so critically important. And then, of course, if you do notice, then you would do an AIMS. So how can a clinician utilize this? Am I saying it correctly here?
Yeah, exactly. So if you kind of break it down, yes, we have the AIMS, which is very important. It's a numerical assessment for the most part, right? It helps us assess the movements in terms of severity, which is great because it helps us track change over time, especially if we are treating. We want to hopefully see reductions in the severity of the movements. In some cases, the AIMS is needed for coverage, right? They ask it for prior authorizations from an insurance company to get access to the FDA-approved VMAT2 inhibitors. But for me, really coming from a holistic standpoint, these tools like the MIND-TD scale help take into account the patient's report of the potential impact of these movements. It's a helpful screening tool, and it really gives clinicians, especially if they're not trained to talk about the impact of TD, because this is something I certainly did not have training. How do you even bring up the topic of TD? So this is a wonderful tool that allows you to ask the questions in a way that a patient may understand and respond to. And the MIND portion can be given over the phone. It can be done via telehealth or in person. And it's really helped me refine and improve my conversation around TD over time in terms of the potential impact that TD can have, whether that be physical, emotional, psychosocial, recreational, impacting leisure time. Of course, it is not a validated instrument. So it is a clinical screener. And as you mentioned, the APA guidelines recommend checking for TD and other drug-induced movement disorders at every single clinical encounter. So this is what we call potentially an informal screener that you can use as that clinical screener in between the AIMS.
Well, that's certainly very helpful. And I think the idea here of getting the patient's point of view is so important. But before we get into that, let's take a second to talk about this differentiation. You mentioned there are other drug-induced movement disorders. And one helpful way I find to think of this is there are the acute drug-induced movement disorders, which would be drug-induced Parkinsonism. And I'm trying really hard, Desiree, to discipline myself to not say EPS. Our neurology colleagues kind of laugh at us because EPS is a non-specific term that can refer to any drug-induced movement disorder. So when we say EPS, we're usually talking about drug-induced Parkinsonism. And then there's three. So the other two are akathisia and acute dystonia.
To the AIMS assessment, what I like about the AIMS, for better or for worse, you actually are able to, in that screener, differentiate drug-induced Parkinsonism from tardive dyskinesia. So in the AIMS, it actually has you looking for gait abnormalities. So in individuals with drug-induced Parkinsonism, you may see that short, shuffled gait. You check for bradykinesia, so are patients having slowed down movements? And sometimes you can also have rigidity. So in the AIMS, you actually check for rigidity, which is not a sign of tardive dyskinesia, but rather drug-induced Parkinsonism or DIP. And we are still looking at the whole person. So if you're looking at this individual and you see the lack of facial expressions, less movement, that may point you to drug-induced Parkinsonism as well as tremors. And tremors can often happen in the hands, but you can actually have tremor in your tongue. You can see a tremor in your chin. But the difference between tremor and tardive dyskinesia movements is pretty simple. Tardive dyskinesia movements, I call them regularly irregular. They're kind of herky-jerky, dance-like, twitch-like movements. Rather, a tremor is very fine and consistent, and you're able to predict that movement from moment to moment. So I would say those two, as you mentioned, DIP and TD, these are the big ones to really differentiate and what you see oftentimes in outpatient clinical practice.
Right. Those are the two most common drug-induced movement disorders, and that's why it's so important to differentiate them. The treatment is actually completely different. So Parkinsonism we think of as a hypokinetic movement disorder, meaning the acute blockade of D2 dopamine receptors means you get less movement. As you said, they're slowed down. There's muscle stiffness and rigidity. There's less facial expression. Their walk is slowed and sort of stooped. We used to call it the Haldol shuffle back when I used to work on the inpatient wards. And there is one, though, hyperkinetic aspect, which is where I think the confusion often comes in, and that's, as you mentioned, tremor, which is regular, rhythmic, and fine. And that tremor is not TD. Tremor is more consistent with Parkinsonism. So you're right that it's really not that hard, I don't think, once you learn that difference, whereas TD is considered a hyperkinetic or additional movements, more movements. And for so long, we didn't have anything to treat TD, so I think that we didn't differentiate. We weren't taught to differentiate as well. And we were taught that the use of an anticholinergic medication, which can work for Parkinsonism and dystonias, well, since that works for some movements, maybe it'll work for every movement. And we were using it and often trained to use anticholinergics such as benztropine for TD, but we now know that is not the appropriate treatment. So it's so important to differentiate, as you said. And let's assume now that we recognize the dyskinetic movements of tardive dyskinesia. Why is it important then, once we've done that, to assess the patient's experience, to get their input on this assessment?
That's a great question. So there's some research out there that shows, it was a survey done with patients and then healthcare professionals, where we as healthcare professionals actually don't do a very good job at matching our patient's point of view. Meaning, I might think a movement is mild, it's just a little eye blinking, or it's just a little finger twitch. So my perception may be much different than the patient's perception. I had an individual that her only movement actually was the increased blinking. And when I told her, I was like, well, this is considered mild on the AIMS. She looked at me and was very taken aback that I had said that to her. And I said, what do you think about that? And she's like, I don't agree that it's mild. My coworkers have noticed. They're telling me maybe I need glasses, and they're bothering me about it, asking me, why I can't see the screen. Do I have allergies? So she was really impacted by the excess blinking from her. She was on a second generation antipsychotic for about a year for bipolar disorder. And I realized from then on, I can't assume the impact, even though it might be mild on the AIMS. The disability is really in the eye of the beholder, as we have said many times with NEI, that this is important to assess the patient's point of view, because ultimately that's going to drive treatment.
That is so well said. And there is often this disconnect. I like to say that TD is more than just a cosmetic condition. It's more than just movements. Of course, we call it a drug-induced movement disorder, and maybe we focus on the presence or severity of the movements in what parts of the body. But as you've said, even mild movements can have devastating impact for someone. And so we can't make the decision for the patient as to whether it's bad enough, if you will, to need treatment. We really do need to incorporate their point of view on this. I think it's also really helpful in your treatment planning and your assessment of your treatment, the ongoing monitoring of your treatment, to have these kind of endpoints. So you can ask the patient, okay, now that we've started treatment here, what are you noticing about the impact? Do you find that people are less noticing this? Are you able to go out socially more and things like that? Has that been your experience?
Exactly. So, of course, I'll do the AIMS. We usually have to submit this for insurance reimbursement, of course, but ultimately I'm treating the person and not the movement. And because both of the VMAT2 inhibitors that are approved in the United States for tardive dyskinesia, they have multiple dosing options. So it's really important to have those goal points, so to speak, with how they're doing and the impact, because we want to make sure that we titrate that medication to up until the patient does not have impact, hopefully, right? So we either titrate up until we hit a ceiling, or we titrate until the patient, that impact has resolved, whether that's pain in the jaw, whether that's feeling embarrassed about the movements. We might not necessarily get the movements, to go away completely, but we want them to go away enough so they're not feeling impacted, they're not having the disability or the pain associated with those movements. So that's something I always like to jot down. in my notes, my clinical notes, and make mention so I can follow up next time to see, okay, where are we at? Do we need to maybe adjust the medication up a little bit? How are you feeling? And it's important to recognize that patients can feel fine for 6 months, and then potentially they could have another situation. Like maybe I had one individual who I got kind of middle of the road with a VMAT2 inhibitor. He was happy. He had the jaw pain and it went away. He was still having movements that were quite noticeable, right?
I see.
But he was not really leaving the house too much. He wasn't out working. He wasn't out socializing at that point. But he came to a point in his treatment where he was doing well. His depression had remitted and he was going out finding a job. He started dating. And it was when he started dating, he came back to me and said, you know, Desiree, these movements, I've noticed that some of the girls have noticed my movements when I've been out with them, and they've been asking me what's going on with my jaw and my lips. So luckily we had some room to titrate, and we were able to get him up to the maximum dose. And we had noticed over several months that people weren't noticing it so much because certainly his AIMS or his TD movements did go down. So it's important to check in with your patients periodically, even if they have been doing well, because life changes. So checking in with your patients is very important.
Boy, I love that. I'm fond of sometimes saying, don't set it and forget it, you know. Be ready to make dynamic changes and adjustments in your dose or in your treatment as the situation changes. That's so well said. Now, we do have, as we mentioned, 2 FDA-approved medications, and Desiree, you're not as old as I am, so you don't realize I practiced for a very long time with nothing until 2017, when all of a sudden we had a bonanza. We had 2 drugs approved, and so now we have these 2 effective medicines, both of which are derived from tetrabenazine, which is an older medicine that has a short half-life. You have to take it 3 times a day, has a lot of side effects, and there these 2 newer versions that are significant improvements and are much better tolerated, easier to take. But how do we start to think about which of these 2 medicines are we going to use, and how does the patient's preferences and the patient's point of view play into maybe my selection and you mentioned dosing, of course, but maybe my selection of these?
Wow, that's a really good question. So first, I will preface to say that in some cases, insurance companies may prefer one VMAT2 inhibitor over the other. So first and foremost, sometimes it's just about, sometimes it's just about what a patient can access under their insurance. Of course, both of these VMAT2 inhibitors, deutetrabenazine and valbenazine, have a very robust patient assistance programs. So at the end of the day, it's generally not a problem. But sometimes you may have that third-party payer hurdle to overcome. But if that's not an issue, we do have to check in with the patient about titration schedule. So both of these medications have multiple doses. Valbenazine has 40, 60, and 80 milligrams that you can choose from. And it's always 1 pill once a day. Deutetrabenazine, this has more of a flexibility with dosing, but if you look at the clinical trials, most patients were on 36 milligrams or more in the clinical trials. So that's when I mentioned it's important to make sure that we titrate both of these medications appropriately, because we want to make sure that we maximize efficacy for our patients. But with deutetrabenazine, in some dosing, you will have to take more than 1 pill, and some patients may not prefer this. Both medications can be dosed once daily, which is important, and they can be both dosed with or without food. So that's just generally not a concern. But sometimes the pill burden or how many pills a patient has to take is something that comes up as an objection. So we have to think about that.
Yeah, great point. When deutetrabenazine first came out, it was twice a day and it was with food. There is a newer version that is the extended release, XR, that is now once a day, and the food restriction has been removed. But as you said, there is still a titration. Can involve 2 different pill sizes for some of the doses. Some of them are just 1 pill. So it is a little more complicated, but I would say that the convenience gap between the 2 has been narrowed a little bit here. What's really fascinating, and our audience may not recognize this, is tetrabenazine has 4 active metabolites. 2 of them are actually VMAT2 inhibitors. And it turns out that these 2 compounds are actually not the same active metabolite. Valbenazine, for instance, is the plus alpha metabolite, which has very high affinity for VMAT2. And deutetrabenazine is the plus beta metabolite, which has high affinity but not quite as high affinity. And the reason I mention this is they're actually two different chemicals, 2 different molecules. So if a patient either doesn't have an optimal response or has tolerability issues with one, it's really incumbent upon us to try the other one and not give up on the concept of a VMAT2 inhibitor. I think that's something that's very important to realize, that they're actually kind of different. And in my experience, some people have done a little better with one versus the other. What do you think about that?
Oh, I completely agree on that. If somebody doesn't do one, whether that be efficacy or tolerability, that is when I go ahead and try the other one. 100%, I agree with that.
Yeah, it's interesting. As a researcher, I've spent my career doing clinical trials. On average, they're both very effective, but, buried within averages, I like to say, are individuals. And so some individuals may have a slightly different, deutetrabenazine does kind of allow for a higher dose range. You can sort of push higher, but there may be tolerability differences and things as well. So we really it's quite a wonderful place to be, to have these 2 different options. So I love what you're saying, that sometimes we feel like, well, we know best, we're going to choose for the patient, but it's so important to get their buy-in and get their point of view, maybe to help select, and certainly, as you've said, in your titration, your dosing schedule, and this kind of thing. Have you had the experience where you bring this up and the patient at first says, well, no, I don't want to take another medicine?
Oh, yes, many times. I think this comes up with a lot of different disease states that we treat in mental health and psychiatry. So what happens when your patient says, well, I don't want to take another pill? This is really where motivational interviewing comes into play, and digging a little bit deeper for potential impact. Because as you mentioned, Dr. Cutler, patients are not always aware of their movements, or that their movement is actually causing a problem. So it's important for us as healthcare providers to be advocates. I had one gentleman, he felt that his TD was not a problem, and he had gone on with living with TD. Mostly he had the jaw opening, he was biting the inside of his cheeks, his tongue was darting in and out of his mouth. He also had some of the classic piano playing fingers going on in terms of his presentation. And he was under my care for 8 years. It took quite many years for him to realize what the jaw movements were doing to the inside of his cheeks. He had opened up sores in his mouth from all of the chewing movements, and he had actually gotten a severe infection from the open wounds in his mouth. And he developed eventually scar tissue that had overgrown on the bite of his molar. So every time he went to take a bite out of something like his food, he had actually started chewing on the scar tissue that was developing over time. Yeah. So this is where sometimes I have to be quite honest with my patients. I can't predict what their TD is going to end up as in terms of severity. I can't predict future impact necessarily, but I really treat TD now as we would in primary care. We want to make sure that we identify it early and we treat it early, because I cannot guarantee that patient is not going to have some type of severe impact of their tardive dyskinesia later on. So I feel like is really part of informed consent and their treatment planning to give them this information that, things could happen later down the road. So maybe we should prevent that impact early on. So that was a really good learning lesson for me, to really be a bit more firm with my recommendations and really use that shared decision-making, motivational interviewing, to let individuals know that, things might not be a problem now, but they could become a problem in the future. This gentleman had actually had to have surgery to remove the scar tissue. So this was quite a severe impact and outcome of his tardive dyskinesia, but he is doing much better now.
Well, I'm glad to hear that, of course. I like to say sometimes we feel pressure to get the patient to buy in and accept our treatment recommendation right away, but I see this as sometimes starting a conversation, starting a dialogue, bringing it up, and then let the patient kind of marinate on that or take it home, maybe discuss it with friend, family member, caregiver. And sometimes then they come back over time and say, yeah, now that you've been talking with me about this, I have noticed this, and maybe now I am ready for this medicine. So I think thinking about this as an ongoing conversation and starting a process and not feeling like you have to seal the deal or close the deal right away maybe is another way to think of this.
Exactly. I usually at least give them some information, whether that be written material, maybe it's a website, maybe it's actually talking to their peer support person that they may be working with in the organization that may actually be living with tardive dyskinesia. Because sometimes, as you said, they really do want to talk it over with family, friends, or people that are important in their lives. And I hate to harp on the LEI conversation, but it's the same thing. We just have to continue to offer and ask and, know the door is always open if they do decide to have treatment for their TD.
Yeah, certainly true. Excuse me. There's also, this is probably a good time to mention that there is an organization called the National Organization for Tardive Dyskinesia, which is actually located near me. They're in Tampa, Florida. I'm down the road in Sarasota, Florida. And they have a website, believe it or not, called tdhelp.org. It's the National Organization for Tardive Dyskinesia, which is no TD. I love that. And I do highly recommend this organization. It's a support organization started by people who live with TD, and it's a terrific resource for patients and their family, friends, caregivers. So tdhelp.org, I would recommend. I'm a big believer, Desiree, I'm sure you are too, in providing information and resources, places for patients to learn more, because sometimes our interactions are limited.
Exactly.
All right. So as we're speaking about this dialogue, are there certain challenges or barriers in communication that maybe we should be aware of or that we can look to overcome in this discussion?
So you did mention patient awareness, and this can be a bit difficult. But I think during the clinical interviewing, using the motivational interviewing in some cases can help patients connect the potential impairment that we quite see clearly in our assessment, whether that be pain, whether that be difficulty wearing dentures or chewing or swallowing. Usually it's a conversation and providing education on what TD is in the first place. Most patients that I've talked to that have developed TD are not even aware that tardive dyskinesia is something that can happen from their medications. So usually it's the first time that they may be even hearing this. So this is the first step is education and letting patients just understand what it is and that it's caused by their mental health medication. So I think first step is education.
Well, that's so important. And I think something else we need to address, let's face it, you and I have both seen patients where they say, well, no one ever told me about this before. And that may or may not be true, because sometimes patients don't digest everything we say. But I think it's so important right up front, as part of the informed consent process, just like you're going to talk to patients about the potential for weight gain or metabolic disturbance, you're going to say, it's possible that some abnormal movements or involuntary movements could happen. So please let me know if you see or notice any abnormal movements. It's very important to start that conversation right up front as part of the informed consent discussion, and not to be afraid of it, not to shy away from it, because that can potentially lead to it being recognized sooner and patient buying in sooner. And we want to also remind them, I would say, you mentioned the gentleman you were treating whose depression got a lot better. These medications, as we know, can be dramatically effective. I'm talking about the atypical antipsychotics. And so we might want to, if this develops, we might want to remind the patient as part of the shared decision-making, don't want to switch or stop this medicine that's really helping you. And yes, this is a side effect, but we can deal with this. We can manage it. Do you have those kind of conversations?
Certainly. The informed consent is so important. And what I actually write and I tell patients up front is that this is a potentially irreversible condition, because in my experience, when patients hear the word side effect, They think, I can stop the medication and this is going to go away. Makes common sense, right?
It does.
Because they may have had this experience in the past. Oh, well, I have nausea or I have this side effect. If I stop the medication, it's going to go away. But oftentimes with tardive dyskinesia, that is not the case. I know some numbers out there say maybe 13% of individuals can remit or have their tardive dyskinesia reverse if the antipsychotic or the offending agent is stopped. So by the time we see most of the cases of tardive dyskinesia, oftentimes it's not going to go away just by stopping the medication. So I think that's first and foremost with education, is letting know this is potentially irreversible, but then follow up with hope. This is what it looks like. Tell them your game plan of how you're going to monitor and use your risk assessment strategies to reduce the likelihood of tardive dyskinesia if at all possible. So especially in my individuals living with bipolar disorder, bipolar depression in particular, I talk to them, well, we have these options that are approved, and these are the ones that may reduce the likelihood of tardive dyskinesia. It's not zero, right? Our second generation antipsychotics, certainly still we see higher rates of TD than I think most of us had expected when they came out. But first and foremost, that is what I like to do, is provide them that upfront, hey, this is what could happen.
Right.
This is what to look for. And then finally, this is the hope. If it does develop, these are the options we have.
Yeah, I think that's a terrific point, Desiree. I think it's important to let patients know that you have a plan, that you can work together and deal with things as they come up, because as we said, you don't set it and forget it. Things can change and evolve over time. You know, you alluded to this stopping the medicine, can it be irreversible? It's really hard. It's hard to accurately assess because a lot of the research that was done on reversibility came years ago when patients had been on meds for a while and the TD had probably been going on for a long time. It is possible that if you catch it early and can stop the medicine sooner, the reversibility might be a little better. But you're right that it is potentially irreversible no matter what, because I've seen people where it doesn't go away even if they've only been on the medicine a short time. Before these VMAT2 inhibitors, the way I was trained was, well, you lower the dose, you stop the antipsychotic, or you switch to something else. Well, the problem is, what if this medicine has been, as we've said, dramatically effective and life-saving for the patient? I mean, lowering the dose, you risk destabilizing their illness. Switching, you certainly risk, especially if it's taken some time to find the right medicine that really works for them. And to be honest, those strategies haven't been shown to work that well. You know, we were told switch to a lower potency drug, for instance. Those things haven't worked as well. And really, the clearly most effective treatment is VMAT2 inhibitors, and they are evidence-based and FDA approved. So there are still people out there who are laboring under this kind of training that you can switch the medicine or do something, lower the dose. That's just not an option for most of our patients. I mean, maybe some with mood disorders, maybe you can get away with a different kind of treatment. But bipolar and schizophrenia in particular, boy, it's really hard. It's really risky to stop, switch, or lower the dose. Don't you agree?
I agree. And patients had gone, in my clinical experience, they have gone through a lot to finally find a medication that they could tolerate and was effective. And this is really the bummer about tardive dyskinesia. It's a ticking time bomb. We don't know when or if an individual is going to develop. And, that's the last thing a lot of patients that have struggled to get into recovery and find some sense of stability and in their treatment plan that, you have a side effect. And I've known a lot of patients, they don't want to hear, we need to change your medications. That can be very anxiety provoking and scary for the individual as well as for the care partners. But the VMAT2 inhibitors is what the APA recommends for first-line treatment for tardive dyskinesia. And if you look at the clinical trials for these medications, for deutetrabenazine and for valbenazine, they simply added on the VMAT2 inhibitor to the patient's stable psychiatric and medical regimen. So this was actually studied in patients that had polypharmacy, because As we know, most of our patients are not just on one medication.
That's
so,
right.
That's another thing I like to tell patients when they're maybe hesitant to take medication. Well, guess what?
Yes.
This was studied to be designed to take it along with your antipsychotic, along with your antidepressants. You don't have to stop your medications. This is just something that is added on.
That's an excellent point that I had forgotten. That is a really good point. That these trials, they simply added the VMAT2 to whatever else they were taking. And yet these drugs were extremely well tolerated. I mean, these drugs have some of the best tolerability profiles that I've ever seen in 30 years of doing clinical trials, to be honest with you. And so that is very encouraging. And you're right to bring that up to the patient that, hey, we have evidence that they can be safely added on and in general, well tolerated. So that certainly can help with that discussion about adding another medication, I suppose, as well. We have to also, Desiree, we've just got to address another elephant here in the living room, and that is that there are still people who believe that anticholinergic medications such as benztropine are effective or are the treatment of choice for tardive dyskinesia. Why is that not true?
Well, we can first look to the prescribing information for our anticholinergics like benztropine, and you will see it clearly in the label that it is to not be used for tardive dyskinesia. In fact, using anticholinergics like benztropine can actually worsen the dyskinetic movements associated with tardive dyskinesia. And why is this? Yeah, I think if you look back, we've used a lot of medications off-label. They weren't necessarily FDA approved, of course.
Sure.
And I thought the same thing. I read the label and I was like, okay, well, my preceptors and I was taught to do this, so this must be the right thing. What was the big eye-opener is understanding the neurobiology and the pathophysiology of tardive dyskinesia. You mentioned that it's a hyperkinetic movement disorder. So unfortunately, one of the big theories of the development of tardive dyskinesia is that being exposed to antipsychotics over time can cause upregulation and hypersensitization of these postsynaptic D2 receptors. So when dopamine does bind to that D2 receptor postsynaptically, because of course we don't block all D2 receptors with our antipsychotics, it can cause abnormal signaling in the motor tract, and thus we see these abnormal movements in our patients. So what happens when we add an anticholinergic, Dr. Cutler?
Well, see, anticholinergics, acetylcholine and dopamine are in a dance. They're in a balance. And if you block the anticholinergic, you actually increase dopamine signaling. Well, that's good if you're talking about an acute drug-induced movement disorder like Parkinsonism, which is acutely decreasing dopamine tone. So I want to restore that balance and increase dopamine. But if you do that in the environment you're talking about, which is upregulated supersensitive dopamine, now making the problem worse, if you will.
Exactly.
So you're right. It's the opposite pathology and the opposite treatments. So how do VMAT2 inhibitors help this situation then?
So by adding a VMAT2 inhibitor in an individual that has tardive dyskinesia, it reduces the amount of dopamine released into the synapse, so less dopamine available to those hypersensitive D2 receptors, and hopefully restoring the balance, and we see less tardive dyskinesia movements. But this was really the light bulb for me on why we should use VMAT2 inhibitors in tardive dyskinesia and not anticholinergics, was really understanding the underlying pathophysiology of the two movement disorders, because they are very distinct. As you can see, the causes are distinct and the treatments are very much distinct and different.
Wait a minute, Desiree. Wait a minute. Are you telling me that everything I learned in training and everything my professors told me is not necessarily true? I have to think for myself?
Unfortunately, I was in the same boat, and I didn't even believe the prescribing information. I had to really dig deep and understand for me to believe that we shouldn't use anticholinergics for everyone.
Yeah. I think you said something else very important. We do use medicines all the time off-label that are maybe not FDA approved, but at least they should be evidence-based. And there are many examples of medicines that have good evidence that they can work, but maybe aren't FDA approved for that indication for a variety of reasons. anticholinergics not only are not FDA approved, they are not evidence-based. There is no evidence that they work, other than we used to just say, well, they work for one movement, so I'll throw them at everything that moves. And that's really, I think, where it came from because of the frustration of not having something effective. So hopefully people will understand that. That's one of the big challenges here. I think the biggest challenge is, as we've said earlier, is just recognizing this, being on the lookout for it, understanding the disconnect between the severity of the movements and the impact, and then recognizing what the appropriate treatment here is, which is really VMAT2 inhibitors.
And circling back, that's why it's so important to be able to recognize in your patients if they are having abnormal movements. Is this drug-induced Parkinsonism? Is it tardive dyskinesia? Or is it both? Because that can also happen. True. And your diagnosis is going to dictate ultimately your treatment options.
Yeah, well, that's really well said, because in any of these situations, including when you see both, it's so important to get the patient's point of view and assess the impact of how much is this bothering them. And in the case of both, you would want to sort of assess which of the movements may be causing more problems or bothering them more. And it's usually, when you have both, usually the TD that's causing more of a problem than the Parkinsonism. But how can we better assess? I guess I want to come back to that. How can we better assess the various domains of the impact? You know, there are many different potential domains here. Physical, emotional, social relationships, work, school. How do we assess all of these areas?
So for me, part of my assessment is a clinical interview. I don't necessarily always use, say, like the Mind TD questionnaire or the Impact TD scale. The Impact TD scale we didn't dive too much into, but this actually looks at the domains in areas of life where TD can affect a patient. So the physical domains, their mental well-being, or psychosocial domains that talks about also vocational, education, recreational, or leisure time. So it assesses these different domains from either no impact to severe impact. But what I like about these clinical questionnaires is that it gives you some really great ways to ask about impact. There was also a great article that I'm sure that you've read. The author was Rakesh Jain, and it was looking at a survey, an online survey of caregivers and care partners. It was published in 2023. And wow, I was surprised reading those questions that patients had to swallow more slowly so they wouldn't have to choke. Patients reported TD impacted their ability to fall asleep. There was a lot that I didn't quite realize as a healthcare professional and someone not living with TD. That was really eye-opening. I really recommend our audience take a look at that paper. It was very eye-opening.
Yeah, I absolutely agree. I mean, things like grooming, getting dressed, tying your shoes, brushing your hair, brushing your teeth can be impacted. Speaking, as you said, swallowing, even breathing. I've seen patients where TD can affect their diaphragm muscles or their pharyngeal muscles. I don't think people realize the full range of impacts physically, like we're talking about here. Of course, we've talked about the effect on someone psychologically. This can make you more depressed or more anxious on top of your underlying illness. It can affect your self-esteem. There's lots of literature on the self-esteem and your self-concept, how you see yourself as a person. There's a terrific series of videos that the two companies have produced, and one of them that really stands out in my mind is when one of the patients said, you know, you feel like you should be able to control this, but you can't. And I feel like that loss of control is so scary for all of us. And that same patient also said, you know, I don't want to feel like a freak. This, you know, marks me as something's wrong or something different or odd about me. You know, mental illness very often is something that is not obvious when you see somebody, but these movements, they mark you, and people are going to say, what's wrong? What's the matter with you?
Certainly. I like to tell people, it doesn't take a movement disorder expert to recognize the movements associated with tardive dyskinesia. People on the street, on the bus, and in group therapy can recognize movements that are not quite normal to somebody. They might not know it's tardive dyskinesia, but they can tell something's wrong.
Yeah, and you gave a very poignant example of the gentleman who was dating. So when we're talking about relationships, the impact this can have on a dating situation, there's also a video of a gentleman and you may know this video, he has rather mild movements, actually. It was a little bit of head nodding, a little bit of jaw movement. But he talks about how devastating it was in a Thanksgiving party, a family get-together for Thanksgiving.
Yes.
He hid in the corner. And so here again is a situation where, to my eye, these were relatively mild movements, but to this gentleman, they were devastating and had significant impact. And so we come back to that again, especially, different patients are different levels of function and have different activities. And so some of our higher functioning patients might be more affected by relatively milder movements. But don't assume that even patients with schizophrenia don't have relationships and aren't going to be impacted by these movements.
Oh, exactly. And even, I cared for a lot of individuals over the years in group homes that maybe they were nonverbal, they couldn't really communicate. So interviewing that care partner or the caregiver that was with that patient was so important, because we've uncovered difficulty with swallowing.
Yes.
Actually, I cared for an individual that was nonverbal and developed tardive dyskinesia on an antipsychotic. And they had actually noticed that he stopped eating some of his favorite foods. Come to find out, he was having difficulty swallowing and choking on some of these foods. So he stopped eating and refused solid foods altogether. He couldn't tell us he was choking. But after talking with several of the nursing staff, we were able to ascertain that, yes, this is indeed tardive dyskinesia. So it's not even just looking for movements. We need to keep our ears open and listen to clues, because sometimes it's not obvious. As you mentioned with the breathing, you have to kind of look, you have to hear. Right. Sometimes you can actually hear people gasping, or you can see kind of the irregular movements of their chest if the diaphragm is affected by TD.
Yeah, and you brought up something that just made me think about one of the biggest risk factors for TD is advancing age. And as we get older, of course, we're more vulnerable to aspiration, and balance and falls are big issues. And TD can actually affect your balance, your gait, as you mentioned. So there's very serious consequences here if we're not vigilant and aren't aggressively treating this, I would say. So we've talked about the physical impact here, the mental, psychological impact, self-esteem, relationships, social leisure activities. I'm thinking about right now, pickleball's super hot. And I can imagine that TD could even affect pickleball playing, and somebody might have trouble with that or might not want to go out and be in public. So it's so important to get that kind of, and these are also, I think these are also very important targets to monitor the treatment. In other words, yes, we're going to do the aims and look at the severity of the movement, but if we understand that person's particular role, what their life is like, what's important to them, and how specifically the TD is affecting the aspects of their life, then we can ask specific questions about how is this affecting this particular thing. And then, as you had mentioned earlier, treat to the impact. That can become a really important part of our treatment plan.
Exactly. And, Dr. Cutler, I know you and I like new and novel things, right? We always like to be on the cusp of what's coming out. So I'd like to talk very briefly, if I could, about the Tardive Dyskinesia Impact Scale, otherwise known as the TDIS. This was this was recently published, and it's a novel patient-reported outcome measure looked at assessing the impact that TD has. And what was great about the development, if you read the manuscript, is it actually included patients and care partners in understanding how they respond to the question. So they actually developed this with the patients and the care partners in mind, and how they respond and resonate with the different questions. And this is actually a validated tool. So in the manuscript, you can actually see as the AIMS scores come down, the impact comes down as well in these individuals. So this is really interesting. It's 11 items, and it covers, as we mentioned, the various aspects of TD, the physical, the social, the emotional impact of TD over a week, so the previous 7 days. And it scored, from 0 to 44, higher the score, the higher impairment or disability. The full questionnaire is not out yet. However,
Okay.
if you take a look at that manuscript, you can see some example questions. So one of the example questions is, over the past 7 days, how difficult was it for you to speak due to the uncontrollable movements of your tongue, jaw, lips, or mouth? So they score it from 0, meaning not at all, to 4, extremely. And you can see in there, they used uncontrollable movements. So they're really using language that is going to be able to resonate with your patient. So I'm very excited to take a look at that full questionnaire when it's available.
So this is the Tardive Dyskinesia Impact Scale, or TDIS. As you mentioned, 11 items. Each item is scored 0 to 4. And who is the first author of the manuscript? How would we find this?
It's Robert Farber, and it was published, I believe, in January of 2024 in the Journal of Patient-Reported Outcomes. It is free full text as well.
Fantastic. Thank you so much. And certainly I look forward to more information on this. This sounds like a terrific tool, and it really sums up everything we've been talking about a tool to involve the patient in the assessment and the ongoing monitoring. And this obviously is going to inform our treatment strategies. Well, we're coming to the end of our time. As always, talking with you, Desiree, time flies. This has been a terrific conversation. I really appreciate it. Do you have any final thoughts around maybe shared decision-making, or how to think about incorporating this into our shared decision-making process?
So I think doing what we always do, listen to our patients and really digging deeper to understand their preferences, their values, so that way we can come together on an agreeable treatment plan that is not only hopefully effective for their tardive dyskinesia in terms of what we see in reduction of movements, but ultimately helps address the impact that they're having in their daily lives. And remembering that the disability of TD, or the impact, is really in the eye of the beholder or the individuals living with the movements, as well as their care partners.
Yeah, well said. I mean, it's so important to understand how it's affecting them and what is important to them in understanding what's our target going to be and what is our goal here. What are we trying to make better? And as you very well said, are we there yet? Do we have room to further push the dose up? Do we need to consider maybe we've kind of hit the limit for one of the medicines or hit some side effects? Do I need to think about switching to the other VMAT2 inhibitor? And I so much, again, want to stress that people need to be very familiar with both and to understand how to use both of them. They're both terrific medicines, potentially very effective and generally very safe and well tolerated. So with that, I really want to thank you, Desiree. I want to thank our audience, and I want to please advise you, please dig into this a little deeper. Hopefully we've given you some thoughts and some ideas. We've given you some resources, including this exciting new scale, the Tardive Dyskinesia Impact Scale. And Desiree, I want to thank you very much for your time.
Oh, thank you so much.
All right. And for more information, more of our NEI educational resources, you can always go to our website, which is neiglobal.com. And our podcasts are available wherever you get podcasts. We've now done quite a number of these. This current podcast is a CME podcast, so don't forget to do the assessment, get your credit. We have other podcasts that are not CME. And of course, we have the very exciting series, the psychopharmacology podcast series, where Dr. Stephen Stahl joins me. Thank you so much, and good luck with your patient care.
Thank you for your participation in this CME NEI podcast episode. To receive your certificate of CME credit, please refer to this podcast's description page for a link to print your certificate. This concludes the CME podcast presentation. For more information about NEI and our premier educational content, please visit neiglobal.com.